So, hello friends. So, I'll be giving an overview on this very devastating sort of a condition that can happen in pregnancy, cardiac arrest in pregnancy. So, this I had to give it as a part of the workshop in Coimbatore for the Foxy obstetric sort of a critical care workshop that we've had. This particular topic, as you would imagine, would encompass more on the ACLS sort of a guidelines for the cardiac arrest that happens in pregnancy. So along with that, so I've tried to put in the key elements that leads to the cardiac arrest in pregnancy from one of the latest sort of a guideline that came from the UK, looking into what are the common causes that happens in cardiac arrest and the way things have to be dealt with. So I would try to cover this topic in maybe 20 minutes. So this would be possibly of relevance if we get to deal with this sort of a devastating condition. So before we embark on cardiac arrest in pregnancy, obviously any emergency in pregnancy, we need to have absolute clarity on certain physiological changes that happen in pregnancy because they have a bearing on decompensation that happens in pregnancy. And we see it quite often. Recently, we had one cardiac arrest just around 10 days back in our ICU, a very affluent family, post LSCS, she had a cardiac arrest, but she survived. So we need to be aware. So I've just put in a pictorial format, although you would see a nice table on the left, the easier way to remember is to grasp this picture in your mind. There are certain variables that tend to increase during pregnancy and certain variables that decrease. If you can stratify that way, it's easy to remember. So the total blood volume increases, heart rate increases, cardiac output increases, stroke volume. Obviously, all these indices increase to make up for the fetal sort of a circulation. So it is quite intuitive if you look at it that way. And the respiratory mechanics, there are certain variables that increase. The minute ventilation increases, oxygen increases, and you would see pregnant ladies would be little tachypneic, tidal volume increases, and oxygen consumption also goes up. So these are the variables that tend to go up. Things that come down, decreases is the overall albumin levels come down. The bicarbonate levels tend to come down. And they have relative some sort of a hypotension. Oncotic pressure comes down. Hematocrit comes down. Because that tachypneic PCO2 tends to come down and there is increase in the SVR. And so this is the variables which tend to decrease. So just have this pictorially. So the cardiac and lung parameters predominantly tend to increase and CO2 comes down, blood pressure will be relatively low, and albumin and oncotic pressure, they go hand in hand, hematocrit comes down. So these are some of the variables that come down. Okay, now when we look at the data for cardiac arrest or maternal mortality, the most robust sort of a data comes from the UK group because this particular narrative on cardiac arrest based on the guidelines has come from UK. So there is a CEMACH is confidential inquiry into maternal health and child health, maternal and child health. So that is the CEMACH, which data predominantly comes from UK. They put maternal mortality at 13.95 per lakh population. And in that, cardiac arrest constitutes 0.05 per thousand. So this is the global data and mainly coming from the UK group where they've collated a lot of data. And this seems to be the more robust data. And the frequency of cardiac arrest seems to have been coming down from 1 in 30,000 to 1 in 20,000. And survival rate with these cardiac arrests is put at around 6.9%, with all the due diligence that happens and all the SOPs that may be put in place to save the life of the mother. And this picture, I think we need to remember the most important aspect is fetal survival is dependent on mother's survival. So whole effort in the setting of cardiac arrest is to obviously save the mother. So I think that should be the tenet of our thought process. The whole effort should not be to save the fetus because the fetal survival depends on mother's survival. So effort is more to saving the life of the mother. So this is something which we need to understand as the quintessence when we are dealing with a cardiac arrest. So this is a sort of data. And if you look at the recommendations there, when I say class 1 recommendation, it is a strong recommendation. And as you see, the level of evidence is C. So there are certain key interventions that the guidelines suggest to prevent arrest. So basically, as the gestation age is more than 20 weeks, there is some aortocaval compression tends to happen, which tends to reduce the cardiac output and reduce the stroke volume. So the positioning of the patient during any hemodynamic compromise should be lateral position, because to eliminate this caval, aortocaval sort of a compression. So when you lie the patient laterally, the blood pressure increases, cardiac output increases, stroke volume increases, and it is also shown that it improves the fetal heart rate and oxygenation. So this is something that has been suggested. Any hemodynamic sort of a decompensation that tends to happen, just positioning the patient in a lateral position tends to improve the cardiac output, stroke volume, fetal viability also tends to increase. And it is suggested that any decompensation that happens, so IV cannula has to be secured. Most importantly, to keep an eye on a blood pressure, not to allow it to go below 100 or less than 80% of the baseline, because that means there is a imminent cardiac arrest that is tends to happen. And any hemodynamic decompensation, patient has to be put on 100% oxygen and try to ascertain the underlying cause that is leading to hemodynamic decompensation and address this. So these are the interim sort of a precautions that one can take to prevent cardiac arrest. If there is some sort of a hemodynamic compromise that may be happening, put the patient in lateral position, give oxygen, secure IV cannula, and monitor blood pressure, preferably with an invasive arterial line, especially if blood pressure is falling down, and prevent from blood pressure going down to less than 100 systolic is what has been suggested from these guidelines. And when there is a cardiac arrest, for all the ICU intensive care specialists or any doctors dealing with it should have this acronym kept in mind. In like in adult cardiac arrest, we say 5H and 5T we roll out. In pregnancy, there is an acronym called BUCHOP. So just it's easy to remember, and it's an acronym. B stands for bleeding. So any cardiac arrest in a pregnancy, it could be due to postpartum hemorrhage or some bleeding of nature. And E stands for venous thromboembolism or pulmonary thromboembolism. A stands for any of the anesthetic drugs during obstetric delivery that has been, it may be spinal or it may be general anesthesia. They can have profound effect leading to hemodynamic decompensation. U stands for uterine atony that can lead to hemodynamic compromise. C stands for some of the underlying cardiac, because many of them would be detected to have congenital heart disease which has gotten worsened or which has sort of decompensated during the pregnancy. They may have background of aortic septal ASD, VSD, so on and so forth, which could have gotten worse during the pregnancy, or it can be valvular lesions. We've had patients with severe MS getting worse during pregnancy and decompensating, having arrest. So we have seen this. Or H is where they have eclampsia, preeclampsia, HELP, and all those other sort of a conundrum that tends to happen due to blood pressure crisis. H stands for hypertension. O is very easy, others. It can be any other sort of a condition. And P stands for placenta previa, which can be lead to PPH and hemodynamic sort of a decompensation. And S stands for sepsis. So this is the acronym BUCHOPS, easy to remember. So remember pictorially. So these are the common causes of cardiac arrest in sort of a pregnant females. So now coming to so patient has had a cardiac arrest. So how do we deal with this? So the chest compressions is suggested should be little less forceful than what happens in adults, and 10 to 20% tilt. As I said, you have to put them in a tilt position so that your cardiac output increases, aortocaval compression is eliminated. If there is no improvement in maternal and fetal hemodynamics, 15 to 30% tilt tends to eliminate the aortic compression. So this is something that has been suggested. But now the recent guidelines suggest that chest compressions in this 30-degree tilt is ineffective. It's not that effective. So now most guidelines suggest lateral displacement of the uterus. So you push the uterus to the laterally and cephalic. So lateral and to the upwards. So there are two studies which have shown this is more preferable because chest compression tends to be a lot more effective with the lateral and upward displacement of the uterus is what has been suggested. And that is class 2A recommendations, moderate recommendations with a reasonable level of evidence. So this is the guidelines suggesting, but you can do tilt initially, improve the cardiac output, stroke volume. But when chest compressions are happening, it is desirable. There is lateral and upward displacement of uterus because chest compressions are found to be a lot more effective. And of course, when you are doing the chest compressions, airway, one has to bear in mind in pregnancy, airway can be difficult because of the airway edema. There can be mucosal ulcerations and oral mucosa is friable. There is increased difficulty that should be anticipated in cardiac arrest situations because failed intubation leads to increased morbidity and mortality. And pregnant ladies, when you're intubating, they desaturate very fast because the shunt fraction is shown to increase from 2 to 5% to 12.8 to 15.3%. So there is a significant sort of an shunt fraction that tends to increase in pregnancy. And one has to pre-oxygenate with 100% oxygen in this setting when you're dealing with airway. And that gets class 2A recommendation, moderate recommendation with moderate level of evidence. So now talking about circulation, because patient has had a cardiac arrest, so we have to follow the algorithms. So the algorithms is very similar to the ACLS, which I'll take you through very briefly. And the drugs, what is there any change because of the increased volume of distribution in pregnancy? The GFR increases. So because all the organs tends to cope up with the fetal sort of a demand. So the GFR increases, plasma volume increases, but the drug dosage, there is no change. So adrenaline, it is 1 mg every 3 to 5 minutes. Vasopressin has been removed from the latest guidelines. Before it used to be there. And amiodarone is something that is there in the algorithm. So I'll just take you through. The algorithm is same as the ACLS algorithms. It's just that lateral and upward sort of a shift of the uterus has to be kept in mind. There's no change in the drug dosaging. So obviously, when there is a cardiac arrest, you have to call for help, code blue, and start compressions. And whilst compression is happening, so you provide with adequate oxygenation and you connect the patient to the monitor and defibrillator. Once you connect, obviously, like in any other standard ACLS, which I'm sure all the intensive care listeners who are listening to this, you look whether there is a shockable rhythm or non-shockable rhythm. So when there is a shockable rhythm, so you provide cardioversion and then continue CPR for 2 minutes. And whilst doing this CPR, you have to secure IV cannula and check the rhythm again. And again, you see if the rhythm is shockable or not shockable. If it is shockable, it's VTVF. Again, you provide the cardioversion and then continue CPR for 2 minutes. At this stage, you have to administer adrenaline 1 mg every 3 to 5 minutes. And then you have to go for advanced airway securing at this particular time if there is no improvement in the cardiac output. And again, check the rhythm and see if it's shockable. Then again, do the cardioversion. At this stage, you may have to consider amiodarone and treat the underlying cause. Now at this stage, you can look for 5H and 5T. And of course, you would have looked at Buchop's. And if it is no shockable rhythm, then you have to see whether it's asystole or PEA, continue CPR, secure airway, advanced airway, and then adrenaline 3 to 5 minutes and treat the reversible. So this is a standard algorithm, what you see in ACLS. It's the same thing that you follow and you repeat these cycles round and round until your rhythm is established. And then you have to, once the rhythm is established, once the output is established, you have to go for post-cardiac arrest sort of a care. So this is the algorithm which I'm sure all of you would have attended ACLS. Just to refresh your memories, it's the same even in pregnancy. So defibrillation in ACLS from the guidelines, the recommended ACLS class 1 strong recommendation is biphasic, it's 200 joules, monophasic is 360. But one has to bear in mind the adverse effects of DC cardioversion in pregnancy because it can lead to fetal deaths. Because you're giving a cardioversion, it can lead to fetal death immediately or post cardioversion, it can happen days because and electrical arcing and fetal arrhythmias also can happen. The risk factors for fetal death is the magnitude, how many times you're given the shock and how many times and how long has the cardioversion been given determine the risk for the fetal death. And this is something one has to bear in mind. And it is reasonable to remove external or internal fetal monitors when cardioversion is happening, moderate recommendation and reasonable level of evidence. So you can't have a fetal monitor kept in place whilst doing defibrillation. So simple things, quite intuitive, but all this has to be kept in mind with specific to cardiac arrest in pregnancy. And whilst you look for Buchop's, don't forget to look for 5H and 5T, which is hypovolemia, hypoxemia, acidosis, hypokalemia, hypothermia, pneumothorax, cardiac tamponade, PE, coronary, and toxins. So don't forget, you look for Buchop's. Along with it, don't forget at this stage to look for 5H and 5T. Okay, now we look into Then what are the reversible causes from scientific standpoint that tends to happen in pregnancy? So 2003 to 2005, CEMACH, which I said confidential inquiry into maternal and child health, primary cause of cardiac as a cause for cardiac arrest was found to be 2.27 per 1 lakh. And in that, the thrombosis accounts for the major chunk at 1.94 per 1 lakh. The common causes of cardiac arrest due to cardiac cause or cardiac ischemia or aortic dissection and pulmonary artery hypertension. So these have been found to be the commoner causes. And 85% of the congenital heart disease tend to survive to the adulthood, which get manifested during pregnancy. So congenital heart disease, they do progress to adulthood and they do get worse during the pregnancy. And these are the situations where there is increased risk of cardiac event. And if there is a coronary ischemia that has happened, percutaneous intervention has to be thought of. And another reversible cause one has to look at is if you are treating preeclampsia, eclampsia, magnesium sulfate toxicity. So you have to look at ECG where there may be increase in the PR interval, increase in the QRS, or increase in the ST. And when there is a suspicion of magnesium sulfate toxicity, they can have hypotension, they can have absent DTRs. Patient can be drowsy and muscle weakness manifest at a level of 4 to 5 millimoles per liter. And hypophosphatemia can be coexist with hypomagnesemia, and this tends to get worse in the setting of hypovolemia. And bradycardia and cardiac arrest on conduction defects can happen at a magnesium level of 6 to 10 millimoles per liter. So obviously, when someone is on magnesium sulfate infusion for eclampsia or preeclampsia, most intensivists, I'm sure, are adept in monitoring magnesium levels and in all likelihood wouldn't allow magnesium to rise to this high levels to cause magnesium toxicity. But nevertheless, this needs to be kept in back of mind when you are dealing with cardiac arrest in pregnancy. So you have to obviously treat by calcium when magnesium levels are very high, stop magnesium and take it from there. And preeclampsia and eclampsia, post 20 weeks, if there is a preeclampsia and eclampsia with decompensation, it can lead to organ dysfunction. It can lead to maternal and fetal morbidity and mortality. So obviously, the first line drugs for preeclampsia and eclampsia as a cause of cardiac arrest in pregnancy is magnesium sulfate, where we give 4 grams for 5 to 10 minutes, followed by 1 to 2 grams per hour for 24 hours. And with magnesium, the blood pressure does not come down. In our practice, generally, we start beta blockers like labetalol. Hydrolysine is also suggested. Labetalol is what we tend to use more often. And as a salvage measure, you can use calcium channel blockers like nifedipine, 5 to 10 milligram every 30 minutes. Second line drug is sodium nitroprusside at 5 microgram per minute, and diazoxide at 15 to 30 milligram every 15 minutes. So most of the time, magnesium sulfate and labetalol pretty much suffices in controlling. It could be topped up with calcium channel blockers is what generally we tend to practice. Very rarely have we used sodium nitroprusside as a second line. And what are the guidelines for delivery in preeclampsia? Patient is in preeclampsia, you're given magnesium sulfate, you have controlled the blood pressure with the labetalol and with sodium nitroprusside. But when would you make a decision of terminating the pregnancy or delivery? So that happens when there is falling platelets, because when you have a health situation, when there is a falling platelets, that is the time when you have to consider delivery of the fetus, or there is a deterioration, neurological deterioration, or there is a deterioration of the liver function, or there is deterioration of the kidney function, or blood pressure is uncontrolled despite all those first and second drugs, or there is an IUGR, intrauterine growth retardation, and there is non-reactive stress test. So these are some of the indications where you would have to terminate or expel the fetus, whatever the stage may be, to save the life of the mother. So this is something. So when there is a deteriorating organ function, obtundation, falling platelets, IUGR, one has to think of delivering the fetus in preeclampsia. And always, which all you intensivists are experts in maintain euvolemia in this situation. So how about life-threatening pulmonary embolism? So there, pulsar PEA can be manifestation where there is a massive PE that tends to happen. Routine fibrinolytics is not recommended, although level of recommendation is weak. But suspected pulmonary thromboembolism, fibrinolytics have shown to improve survival. As you see, moderate recommendation and moderate evidence. Emergency echo has to be done to look for any thrombus, and percutaneous mechanical thromboembolectomy has to be considered as a life-saving measure. You may have to give fibrinolytics to improve the survival in these situations. And obviously, you have to involve cardiologists and cardiac surgeons. And nowadays, percutaneous thromboembolectomy is being increasingly done. So that should be considered at the earliest if there is a massive PE. And obviously, you have to start anticoagulation. So, and surgical embolectomy as a salvage measure. So amniotic fluid embolism, this is a devastating complication. In fact, 10 days back, we had an affluent patient who came with cardiac arrest. We did suspect pulmonary embolism, pulmonary thromboembolism, so on and so forth. And amniotic fluid embolism is a diagnosis of exclusion. It is based on suspicion. There's no clear sort of a indicators to suggest that it is a clinical sort of a diagnosis. So you may have to consider VA, ECMO, or bypass. The diagnosis is basically by identifying squamous cells or fetal debris in pulmonary circulation. There's a separate video. I've done an amniotic fluid embolism. I request you to watch. There are three variants. One is where there is a mainly predominantly neurological manifestations. The second is where they present as ARDS. The third is where they present as sepsis or DIC or a lot of bleeding, coagulopathy, lung manifestations, and neurological. So those are the three sort of a manifestations they can present with. So there's a separate video. And if there is amniotic fluid embolism suspected, you would have to think of ECMO or cardiopulmonary bypass, and perimortem LSCS has to be considered to improve maternal survival and neonatal survival. So it's a separate video. You can go and watch. So they predominantly manifest either with like an anaphylaxis with a bronchospasm and respiratory failure, or hemodynamic compromise, or DIC and neurological manifestations. And other complications like anesthetic complications. So anesthetic complications leads to maternal morbidity and mortality. So one has to adopt to the sound principles of obstetric anesthesia to minimize the complications of anesthesia. So cardiac arrest. In fact, our patient who came with cardiac arrest, we suspected amniotic fluid embolism and maybe some sort of a high spinal is what we thought. So cardiac arrest can be due to spinal shock and can be due to loss of airway, can be due to aspiration, can be due to airway. So these are the common causes or anesthetic causes of cardiac arrest in pregnancy. If that happens, you have to adopt your ACLS algorithms. And most importantly, you have to look at perimortem sort of a LSCS or emergency cesarean section has to be thought of, where if you are contemplating on normal delivery and cardiac arrest happens, you have to shift to emergency LSCS. So now I think this is important. We'll just move to what defines gravid uterus with the potential to cause aortocaval compression. Any pregnancy more than 20 weeks are at a risk of aortocaval compression, and exact gestational age needs to be known to determine whether there is a significant aortocaval compression. And if you see, if you look at this picture, more than 20 weeks of gestation interferes with maternal hemodynamics. So and this tends to increase with every passing week after 20 weeks. And there can be confounding variables like obesity and abdominal distension. And there have been two case reports where cardiac arrest have happened within 13 to 15 weeks, where no LSCS was performed and patient did survive. But these are all case reports. Otherwise, most often one has to resort to perimortem LSCS to save the life of the mother. So this is a very important aspect. So pay attention. Why perform an emergency CS in cardiac arrest? So emergency CS has to be considered to have a return of spontaneous circulation and improve maternal hemodynamics. So emergency CS has to be considered more than 20 weeks to save the life of the mother and to improve maternal hemodynamics. So this was one study where 38 patients, they did a perimortem cesarean section, and they found return of spontaneous circulation happened in 12 out of 20 patients, and worsening of maternal status did not happen in any, which means after 20 weeks, aortocaval compression, cardiac arrest, perimortem LSCS has to be considered to improve maternal hemodynamics and to improve the survival of the mother, because the survival of the mother is quintessential for the survival of the fetus. So this is important for all the listeners. The importance of timing with emergency CS. If you look at this timing, friends, it is quite staggering and quite looks formidable that it has to be done in 5 minutes. So the BLS and ACLS has to be initiated, and if no cardiac output within 5 minutes, so termination and perimortem CS has to be considered. Yep. And with emergency CS, maternal prognosis also is grave. If it is not done, unlikely survival. Even with emergency CS, the maternal prognosis can be grave. Perimortem CS recommendation is to be done within 5 minutes. But just imagine practically how feasible it is to do within 5 minutes. But they've said at least aim for less than 15 minutes has shown to improve survival. And very often it is shown that within 5 minutes to perform a CS, LSCS is difficult, but that is the recommendation, class 2B recommendation, moderate recommendation with reasonable good level of evidence. And it is shown that best survival if the gestational age is more than 24 to 25 weeks, more than 24 to 25 weeks, perimortem CS has to be done within 5 minutes. But if it's more than 30 weeks, your gestational age is more than 30 weeks, then survival is better between 5 to 15 minutes. So, which means it's like how we say administer antibiotic within 1 hour. Not necessarily we can administer for all patients like that. ASAP is the norm. Perimortem CS has to be attempted to be done within 5 minutes, especially if gestational age is less than 25 weeks. If it is more than 25 weeks, maybe you can have little relaxation up to 15 minutes is what has been suggested. So, as I said, emergency CS in gravid uterus is class 1 recommendation, strong recommendation and moderate level of evidence. And in gravid uterus, again, the recommendation is 4 minutes, 4 to 5 minutes. Basically, every second is very valuable. So class 2B recommendation, level of evidence is C. So the whole aspect of cardiac arrest is institutional preparation is the key. So one has to be prepared for this. So you should have the code blue team and you should have the whole teams put in place to save the life of the mother. And one has to always look at the feasibility of emergency hysterectomy. Don't waste time. So, and it is a teamwork. It is a teamwork of intensivists. So when we had a cardiac arrest of an affluent lady, very precious pregnancy just around 10 days back. We had intensivists, we had obstetrician at the bedside, we had anesthesiologists, and we had neonatologist also in place. And luckily, this patient has had a cardiac arrest after the expulsion of the fetus. We saved the life. She had cardiac arrest, 1 cycle of CPR, she improved. We did all the works, echo and everything. She improved, we extubated, she's fine, she's a happy mother now. So what it means is, my only observation is now any precious pregnancy where you are anticipating complication, the delivery should happen in a multi-speciality hospital because single specialty hospital may not necessarily have, like women's and child care, may not necessarily have a full-fledged ICU team to take care of the patient effectively and save the life. They may not have ECMO or they may not have immediate cardiology services. So my submission is if it's a high risk pregnancy where you're anticipating complication, delivery ought to happen in a multi-speciality where all the teams are present to save the life of a valuable mother. Hypothermia, although the latest guidelines do not recommend hypothermia, this is the older recommendation. But now the whole understanding is you have to maintain normothermia and don't allow fever to develop in these patients. So the summary of cardiac arrest, understand the quintessence is understand all pregnancy is not normal. There are a lot of physiological changes that happen in pregnancy. And always remember this picture. Survival of fetus is dependent on survival of mother. Your whole focus should be to save the life of the mother. And most importantly, there's always underlying cause for the cardiac arrest. So think of blue chops, whether there is bleeding, whether there is embolism, whether there is uterine atony, whether there is obstetric problems, so on and so forth, and any other underlying cardiac problem that patient have had. And when you are resuscitating a pregnant lady with hemodynamic compress, simple thing, lateral and upward displacement of the uterus. And if that is not possible by intensive, just put them on lateral position that improves the cardiac output, improves the stroke volume. And if there is a gravid uterus, emergency CS has to be considered within 5 minutes. Even less than 24 to 25 weeks, all the more reason it has to happen within 5 minutes. If more than 25 weeks, up to 15 minutes, you have that window. And preparation is the key. and multidisciplinary team effort is what goes in to save the life of the mother. So thank you, friends. So request you all to submit your valuable work to Journal of Acute Care. Of course, you can visit my website to rehear to these lectures. Thank you. Thank you, Varun.